In this video, I would like to summarize point-of-care testing, also known as bedside testing for medical students. Point-of-care testing, POCT, refers to diagnostic testing conducted near or at the site of patient care, outside centralized laboratories. Its primary goal is to deliver rapid, actionable results that can inform clinical decision-making immediately, especially in acute and primary care settings. There are several other synonyms for POCT, such as bedside testing, emergency testing, critical care testing, patient-focused testing, near-patient testing, decentralized testing, and self-home monitor testing. However, we prefer the use of point-of-care testing, POCT. The first documented bedside, or rather point-of-care, test dates back to papyri from around 1550 BC, when Egyptian doctors used ants to detect glucosuria in suspected patients with diabetes. A similar POCT test was when the doctor tasted the patient's urine to see if it was sweet. The assured criteria, developed by the World Health Organization, WHO, outline the ideal characteristics for point-of-care diagnostic tests, particularly in low-resource settings. Assured stands for affordable, sensitive, specific, user-friendly, rapid, robust, equipment-free, and deliverable. Affordable means that the test should be reasonably priced to ensure accessibility, especially in resource-limited settings. Sensitive. The test should be able to correctly identify those who have the disease with a low false negative rate. Specific. The test should be able to correctly identify those who do not have the disease with a low false positive rate. User-friendly. The test should be easy to use, requiring minimal training and expertise, and ideally not need a laboratory setting. Rapid and robust. The test should provide results quickly and withstand varying environmental conditions and handling. Equipment-free. Ideally, the test should not require complex or expensive equipment to operate. Deliverable. The test should be easily distributed and available to the end users. The global point-of-care testing market size was $39.64 billion US dollars in 2024, grew to $44.48 billion US dollars in 2025, and is projected to surpass $125.33 billion US dollars by 2026-2034, representing a healthy compound annual growth rate, CAGR, of 12.20% between 2024 and 2034. The North American point-of-care testing market size is estimated at $18.23 billion in 2024 and is expected to grow at the fastest compound annual growth rate of 12.31% during the forecast period. Clinical relevance and advantages of POCT, timely diagnosis and treatment. POCT allows clinicians to bypass delays associated with laboratory turnaround times. Immediate results are particularly critical in managing infectious diseases, emergency conditions, and monitoring chronic diseases, e.g., glucose, HbA1c, INR. Improved patient outcomes. By shortening the diagnostic cycle, POCT helps reduce unnecessary treatments, optimizes antimicrobial use, e.g., for influenza, and enhances patient satisfaction and trust. Utility in various settings. In primary care, it is used to avoid unnecessary referrals, provide reassurance, or initiate appropriate treatment, e.g., CRP for respiratory infections. Resource-limited regions. Essential where laboratory infrastructure is lacking. Epidemics and outbreaks are critical in detecting, isolating, and tracking cases quickly, e.g., COVID-19, dengue, hepatitis B. Let's take a closer look at what these uses might be. For example, in emergency and acute care, it is essential for rapid diagnosis, as well as in the case of significant injuries for effective triage. In the case of a heart attack, testing for myocardial markers, e.g. troponin, can help diagnose myocardial infarction. Blood gases and electrolytes in respiratory distress or shock, monitoring acutely ill patients by measuring the lactate levels in sepsis, the glucose, and the ketones in diabetic emergencies. In primary and outpatient care for early diagnosis and screening of HbA1c for diabetes monitoring, or urinalysis for urinary tract infections, pregnancy tests, and measuring hCG levels. For respiratory tract infections, for example, rapid streptococcal tests, flu and COVID-19 antigen tests are available. For chronic diseases, for example, glucose measurement in diabetic patients, or for long-term tracking hemoglobin A1c, or for anticoagulation monitoring, INR level determination in patients treated with warfarin, but also in the operating room or during anesthesia can be very relevant, for example, for real-time monitoring to measure the amount of electrolytes in blood gases or the coagulation status. E.g., during surgery, the activated clotting time or thromboelastography to determine the patient's coagulation parameters. Transfusion to determine the blueness of the hemoglobin or hematocrit measurements. In intensive care units and emergency care settings, where continuous decision-making is required, knowledge of electrolyte levels, lactate, blood gases, and glucose control, particularly in patients receiving insulin, is crucial. In neonatology and pediatrics, this is a minimally invasive test. It measures bilirubin levels in newborns, monitors glucose levels in suspected hypoglycemia, and performs blood gas analysis in ventilated neonates. Rapid tests are also essential for detecting infectious diseases, such as HIV, hepatitis C virus, syphilis, COVID-19, and influenza. It is also necessary in cases where there are insufficient resources, for example, in rural or African areas, for the treatment of malaria, dengue fever, and tuberculosis. Pre-hospital and ambulance tests, such as blood glucose level measurement, cardiac enzyme measurement, blood gas analysis, and lactate measurement in traumatized or septic patients. In rural areas far from healthcare facilities, it can provide essential access to testing for biochemistry, hematology, and infection screening, for example. It allows diagnosis and referral decisions to be made in resource-poor areas. For home self-monitoring, as mentioned above, there are blood glucose monitors, home INR monitors, home pregnancy and ovulation tests, all of which are covered by POCT. This figure shows the difference when the patient is examined under normal circumstances. For example, a patient arrives in connection with a mass casualty incident. A sample is taken. The sample taken is sent to the laboratory. The laboratory prepares the samples, then performs the tests, validates the results, and sends them to the doctor. The doctor then makes a diagnosis and chooses the appropriate therapy. However, when the POCT test is performed, the sample is collected on the spot and can be taken directly to the test kit. The analysis is done within a few minutes, and the patient can be seen immediately. If necessary, you will be hospitalized. If not, you will be discharged home. What types of technology do these tests use? Well, perhaps the most common are these lateral flow tests, which include pregnancy tests and rapid antigen tests. They can also be used for enzyme detection, which are rapid tests but have limited sensitivity. In the following video, I will show how this works.
Lateral flow assays are low-cost, rapid, and easy-to-use tests which make them ideal for many different applications. In principle, lateral flow assays are immunoassays that utilize antibody-antigen interactions to detect specific targets or analytes. These targets can be anything from infectious diseases such as influenza or COVID to allergens or hormones such as HCG to detect pregnancy. The most common type of lateral flow assays are sandwich immunoassays. In these assays, conjugate antibodies first bind an antigen. This complex then travels toward immobilized antibodies by capillary action. The immobilized antibodies bind the same antigen at a different binding site, thus creating a sandwich. The process of how this works in a lateral flow device will be explained in detail later. The main components of a lateral flow assay are the sample pad, conjugate pad, nitrocellulose membrane, and wicking pad. All these components are assembled together on an adhesive backing card, and strips are commonly assembled into plastic housing cassettes. Some lateral flow devices are placed directly into the sample in a dipstick format. Lateral flow assays are intended for many different sample types, ranging from clinical specimens such as blood, urine, stool, or respiratory specimens, to samples like food, water, or environmental samples. Run a lateral flow assay. First, the test sample is applied to the device via the sample pad. The sample pad may or may not be treated with certain agents to neutralize the pH of the sample and block non-specific binding interactions by molecules other than the target of interest. The sample flows through the device by capillary action. The sample will come into contact with the conjugate pad next. The conjugate pad contains a mobile antibody bound to a label. This labeled antibody is also referred to as the detection antibody. Once the sample comes in contact with the detection antibody, and if the antigen is present, the antigen will bind to the detection antibody at the specific site that the antibody recognizes. This binding site is also called the epitope. In most cases, the label on the detection antibody is colloidal gold. There are other types of labels as well, such as colored latex particles and cellulose nanobeads. The label is what allows the visual detection of the target or antigen. If the device uses a colloidal gold label, the color of the line for positives will be red. From here, the sample continues to flow through the device and makes contact with the nitrocellulose membrane next. The nitrocellulose membrane contains immobilized antibodies, striped and dried in a line format. The first immobilized antibody line is the test line. It contains the capture antibodies, which will recognize a different epitope from the same antigen recognized by the detection antibody. This is where the sandwich assay will occur if the analyte is present. As more and more of the antigen-antibody complex binds to the capture antibody, the color will start to appear and darken. Anything that does not bind to the capture antibody will continue to flow across the nitrocellulose membrane until it comes in contact with the second immobilized antibody line, the control antibody. Any detection antibodies that did not bind the antigen will be recognized by the control antibody and will be bound at the second line where a colored line will develop. The remainder of the sample will continue to flow through the device until it is absorbed by the wicking pad in order to prevent the sample from traveling backwards through the device, which can cause erroneous lines to form.
The second is the nucleic acid amplification test, which detects genes through isothermal PCR amplification, e.e., genetic material, such as viruses, including influenza, COVID-19, or hepatitis B. They have high sensitivity and specificity, and some types can even be carried out in the field, i.e., in conditions where there is no nearby infrastructure. They have high sensitivity and specificity. Some versions are adapted for field settings.
PCRD is a rapid nucleic acid detection test designed for supporting migration of molecular testing from the laboratory to point of care. Available in 2 formats for use alongside isothermal amplification, PCRD uses lateral flow technology to detect labeled amplicons in minutes. Nucleic acid detection using PCRD is straightforward. Only 5 steps are required to start using PCRD. Label your primers or probes. Then carry out the amplification protocol as normal. Add the amplified reaction sample to the PCRD buffer. Mix and apply to PCRD. Upon sample application, the carbon particles will bind to the target amplicons before being captured at the test lines by the immobilized antibodies. After 10 minutes, record the result.
Biosensors are the third type of POC test. These can be electrochemical, optical, or piezoelectric sensors. They typically feature a disposable cartridge, enable real-time virus detection, and can even be connected to a smartphone. The patient can see it straight away. Or there are cases where the doctor, the GP, can get these values. For example, in the case of glucose meters. You can see this in the following video.
What is a biosensor? A molecular biosensor is a sensing device that measures specific molecules known as biomarkers. Molecular recognition is used for detection of biomarkers, working in conjunction with the reader. The biosensor operates by detecting a sample taken from the interstitial fluid and is worn either inside or on the body for continuous monitoring, with glucose being the most common biosensing device used by diabetic patients. The process begins with molecular recognition, followed by signal generation, reader instrument, and a disposable sensor device. Biomarkers bind to the recognition molecules, and they can be either an antibody, an aptamer, or an enzyme. This results in a signal generation inside a disposable sensing device, and the signal can be optical, electronic, or magnetic. The signal is then translated, and the disposable sensor device then displays this into data and information that is user-friendly and easy to understand. Our biosensing devices have a wide range of capabilities that can be applied to different aspects depending on the user's specific needs. In recent years, we have developed biosensors used in the analysis of food, such as chili, garlic, ginger, and star anise. We have a point-of-care exhalation technology that detects analytes in the breath. More prevalently, a device that aids in COVID-19 detection rapidly. Another application is nitrate sensing in soil using our nitrate rods, used in conjunction with the user's smartphones for continuous monitoring.
The next one is CRISPR-Cas9-based diagnostics. This is an interesting one and uses bacteria's defense against viruses to identify different nucleic acids and viral particles. It's used primarily for tracking endemic infectious diseases, especially in environments with limited resources. This is demonstrated in the following video.
For billions of years, bacteria have been under attack from viruses. But bacteria developed clever defense mechanisms to remember these viruses and fight back. Recently, scientists harnessed one of these natural tools called CRISPR-Cas9 and created a powerful gene editing technology with the potential to treat human disease. But Cas9 isn't the only CRISPR tool with applications for human health. A team of scientists found that a cousin of Cas9 called Cas13 can be harnessed to actually detect human disease. Here's how Cas13 works in its natural environment. First, it hunts for viral RNA using an RNA guide. When it finds its viral target, Cas13 becomes activated. In some circumstances, it cuts any RNA it encounters, a process termed collateral cleavage. It is this mechanism that scientists to create a highly sensitive tool to detect infectious diseases in humans. Here's how their lock detection system works. First, researchers take a sample from a patient with a possible viral infection, like the flu. Then, they amplify the levels of RNA in it and add reporters that are sensitive to Cas13. Then, an engineered CRISPR-Cas13 is added to the sample. This Cas13 is programmed with a guide RNA that is designed to find only virus RNA and bind to it. When this happens, Cas13 activates its cleaving mechanism and begins randomly slicing nearby RNA, including the reporters. Since each end of the reporter carries a different label, Cas13 separates these two signatures, creating a unique signal within the sample. The sample is then applied to a commercial flow detection system. If the sample is negative for flu, the reporter remains intact and collects at the first detection line. If the sample is positive for flu, it collects at a different location, making a diagnosis easy to spot. It can be used in the field to detect emerging infectious diseases and outbreaks, like Ebola virus. It can be adapted to detect any genetic signature, even ones associated with cancer, in virtually any location. CRISPR-Cas9 and Cas13 are just two examples of natural biological systems that scientists have modified to fight genetic and infectious disease.
And then, of course, the platforms that are integrated with the smartphone. We've already talked about some of this, even for monitoring glucose, which can be, for example, the fingertip measurement. We'll read it here. But in the case of someone who has a monitor like this, a glucose monitor implanted in their arm, they can check it either through their smartphone or even through their smartwatch. And even during a pandemic, you can check for the COVID-19 virus.
Continuous glucose monitors, commonly abbreviated as CGMs, are small devices that sit just on top of the skin with a small catheter that goes under the skin and measures your blood glucose level periodically. They provide an easy way to always know what your blood sugar is without having to check using a meter. CGMs come in many shapes and sizes, but all perform generally the same task of reading your blood sugar continuously. Different CGMs have different ways that you read your blood sugar, but most CGMs will come with a receiver specifically designed for the CGM that you can read your blood sugar from. Some CGMs also offer a mobile app that you can use to check your blood sugar on your phone or smartwatch. This method offers a convenient and easy way for you to keep track of your blood sugars without having to remember to bring a receiver. Here are some things to remember when using it. One major difference between glucose readings from a meter and a CGM is that the meter measures the glucose in the blood, while CGMs measure the glucose in the fluid that surrounds the cells in the body. This often means that the CGM has a slight delay when reading glucose, so you may see a difference between a meter and a CGM if you test right after you eat or take insulin. The most will be changed once every 7 to 10 days. It is important to remember that when traveling with CGMs, they cannot go through X-ray or full body scanning machines. These machines can damage the sensor and transmitter. One important thing to remember about CGMs is that they are not always perfectly accurate. If the reading that your CGM is giving you seems incorrect or you feel differently than what your CGM says, test with your meter. Remember, when in doubt, get your meter out.
Advantages of POCT. Rapid results enable timely decisions. Obtain results in 5 to 15 minutes. Significantly accelerating diagnosis and management compared to central labs. Critical in emergencies, e.g., cardiac enzyme, troponin, blood gas, and lactate measurements, leading to faster interventions. Time is muscle in myocardial infarction. Improved workflow and patient experience. Reduces the need for patients to return later or wait for lab results. Enhances satisfaction and treatment adherence. Promotes antimicrobial stewardship by supporting on-the-spot decision-making, e.g., CRP testing. Enhanced accessibility and flexibility. Facilitates OH general family care, pre-hospital emergency care, community clinics, and home settings. Especially valuable in resource-poor regions and during outbreaks, such as dengue, monkeypox, and HBV. Integration with digital health. Results can be fed directly into electronic health records via mobile or cloud platforms, promoting continuity of care. Potential cost savings. Although per-test costs may be higher, overall savings can accrue via reduced hospital stays, more efficient triage, and higher patient throughput, e.g., bedside troponin testing yielded net benefits even after accounting for labor costs. We also need to discuss the disadvantages of point-of-care testing, POCT, analytical limitations. Many POCT tools exhibit lower sensitivity and specificity compared to centralized assays, thereby increasing the risk of false positives or negatives. Pre-analytical and user errors, incorrect sample types, poor handling, lack of calibration, or improper use can compromise accuracy. Quality management challenges, maintaining quality assurance and quality control. QA/QC outside laboratory settings is complex, as issues such as temperature control, reagent storage, regular proficiency testing, and oversight are essential. Higher unit costs and resource needs. The costs per individual test and training, as well as dedicated staff for quality assurance QA oversight, can be substantial. Data and documentation issues, poor interoperability, lack of standardization, data duplication, and confidentiality concerns are common. Regulatory and accreditation demands. Compliance with regulations such as the CLIA, USA, CE marking, and ISO standards Europe requires oversight, documentation, and certification. This table summarizes both the advantages and disadvantages. The benefits include a faster result for acute care. However, it has lower test accuracy. The advantage is better patient engagement and cooperation. And because patients don't have to go to the hospital, they don't have to go to the lab. It can be done there on site. However, prenatal and postnatal errors are there. For example, the blood collection point is not cleaned correctly, or the sampling is not done properly, or the instrument is not calibrated correctly. Therefore, numerous problems can arise that limit the reliability of point-of-care testing, POCT tests. And then you have access to these POCTs in different locations, different districts, very easily. However, quality control testing, or even compliance with quality control criteria, is quite complex and not always adhered to. They can be integrated into a digital system. Yes, but the disadvantage is that the cost per test is higher, and the training burden is greater, because those who are trained, i.e., who perform these tests repeatedly, can measure properly with these tools. Overall, it could potentially be cost-effective to have, for example, a POCT test. However, data and documentation regulations can present challenges for physicians in patient care, so the two need to be adequately evaluated in our case. Risk of POCT. It can act as an infectious reservoir for nosocomial and antibiotic-resistant organisms. Blood glucose testing devices have been linked to the transmission of hepatitis B infection among patients. Although it may seem simple, these devices are not innocuous. Consumers and operators of these devices must be aware of the potential risks and take steps to ensure the quality of their tests is appropriate. We must mention some key points about the environmental effects on POCT. Unlike the core lab, POCT occurs in various conditions and settings. Reagents for POCT are sensitive to heat, light, and moisture. Reagents shouldn't be frozen or overheated. Pregnancy kit. The antibody is a protein and can be denatured at high and low temperatures. Urine dipsticks and occult blood test devices are chemically degraded by more light, heat, and humidity. It should be stored in dry cabinets, away from sources of moisture. Test kits left in the trunk of a car and the back of an ambulance can freeze in winter and cook in summer. Blood gas device calibrated at sea level. The performance of POCT at higher levels, such as in helicopters or pressurized air cabins, may be affected. Some words about the implications for medical students. Complementary use. POCT enhances rapid decision-making but does not replace central laboratory testing. Confirmatory testing is often necessary. Rigorous training and oversight. Proper sampling, operation, calibration, and QA/QC competence are fundamental. Critical interpretation. Being aware of a test's accuracy metrics and limitations, e.g., false results, interference, is essential. Ethical and regulatory compliance. Maintain confidentiality, document results accurately, and adhere to legal guidelines. Evidence-based application. Understand the evidence supporting POCT efficacy and cost-effectiveness in clinical contexts. Emerging trends in the technology of POCT. Multiplexed POCT x POCT enables the simultaneous detection of multiple analytes from a small sample, making it promising for cancer and chronic disease monitoring advanced technologies. Deep learning enhanced assays for cardiac markers, e.g., troponin, achieving lab-grade sensitivity. Smartphone-based platforms offer comparable accuracy for lipid monitoring and other biomarkers in decentralized settings. In conclusion, point-of-care testing, POCT, is a transformative tool in modern healthcare, providing rapid, decentralized diagnostics that can significantly enhance patient outcomes when used appropriately. Medical students should grasp both the tremendous potential and the limitations of point-of-care testing, POCT, and be equipped to integrate it wisely into clinical care.